Hi, good evening. Thank you for joining us. This past week, as people have been hearing about the Health and Halacha event, and our topic specifically, pelvic floor dysfunction, I've been having more and more conversations about this and hearing about situations of people experiencing pelvic floor dysfunction. Tonight, myself, Yoetzet Halacha Bracha Rutner, along with Dr. Scott Chudnoff and physical therapist Rivki Chudnoff, will talk to you about pelvic floor dysfunction and show you the interplay between medicine and halacha. Scott, if you could go ahead and share with us questions.
Okay, so for those who are unfamiliar with some of this polling, this is actually a really simple thing. Anyone who's paying attention, if you don't mind, if you just were to text to the number 37607, text the word Scott Chud, SCOTTCHUD, right over here. Text to this number 37607. The word Scott Chud, and then you can enter the poll. You can also do it if you're on a computer and you want to go to a website, pollev.com/Scott Chud, and you'll be able to enter the poll and put in your responses. And this way we can start to get an idea of who's tuning in with us here. And then if you just answer your responses based on how old you are. And we'll give it a minute or so. Sometimes it takes a few seconds for the poll to launch up. And throughout the evening tonight, we're going to be going to some of these polls because it's really kind of hard for us to interact with everyone one-on-one in these virtual settings. But this is something that we figure is an opportunity for us to be able to get an idea of who's here, and this way we can help to tailor what we're going to talk about with you guys. We'll give it about another 20 seconds or so. All right. A couple of late entrants there. We'll give it another few more seconds.
I feel like it's one of those carnival games that, like, when you got the horses going, it's like, who's gonna win? Who's gonna win?
Well, I think we're seeing our dominant number here. Wonderful. All right. So we have a fairly good distribution, although it seems that 26 to 35 seems to be our largest number here. Now, one of the other things is that, when we talk about pelvic floor dysfunction, a lot of different things, most people probably don't even know what that actually means. And what I'd like everyone to do is, if you don't mind, just what word comes to mind when you think of pelvic floor dysfunction? You could type it, text it. You could text more than one word if you have more than one word that you think is applicable. But just feel free to text it in, and we could see what everybody has to say. And just so people at home understand, the way that this works is the more common that a word is being said, it gets a little bit bigger. It's always interesting seeing the responses. I'll give it a few more seconds for people to get their final responses into us. And I think it's important that when we talk about, we're going to move forward and we're going to talk about some cases, and I know Bracha will introduce in a second just some of the cases. But, when we talk about pelvic floor dysfunction, it's interesting because, we throw that term around, and the fact of the matter is a lot of people have no idea what pelvic floor dysfunction actually is. And we're going to go through some examples of pelvic floor dysfunction as we go through this talk. But I think that, you could see here the things that the most common words that are popping up: pain, incontinence, leakage, prolapse. But we see all these other things in here too about awkward, control, bladder, embarrassed, uncontrollable, tightness, constipation, pleasure, or probably lack of pleasure, I think is what it's referring to there. So there's really a lot of different ways in which pelvic floor dysfunction can impact different people. And so, I think that I'll let Bracha take it away from here.
Okay. Thank you so much. You may yourself have experienced pelvic floor dysfunction, or you may know someone who has. I wanted to share with you tonight, working with Scott and Rivki, and talking to you about different ways that pelvic floor dysfunction can express itself at the different stages of life, and what might happen when a woman calls me with pelvic floor dysfunction or a question surrounding it. So if we look at the case, we're going to look at 4 different case studies. We're going to start now first with a case study of a woman who is newly married. And in this case, a young woman has just gotten married. She's grown up in a halachically observant household, and she took halacha classes in which her teacher discussed intimacy and intercourse. So in this case, she's got some familiarity. She's had the discussions. And she also visited her gynecologist for a checkup prior to her wedding. And everything seemed fine. However, she and her husband have struggled to consummate their marriage. They've tried different positions, they've used lubricants, but nothing really seems to be working. And any attempt that they're making at this point is extremely painful and really feels impossible. So if we think about this, when a woman calls me, first I want to break down exactly what the issues are here, and then what I might go ahead and do when a woman calls me like this. So here's a young couple who's having difficulty consummating their marriage. They may have tried some different solutions and nothing seems to be working. And the woman is also experiencing a lot of pain. In this situation, I would likely refer a woman to either an OBGYN or a physical therapist. Now, Scott, if a woman like this came to your office, what might you ask her or advise her?
I think there's a lot of pieces to this and a lot of directions that I would think of that we go with. There is a poll up here that people, while we're just having this discussion, if you don't mind, just to see whether or not you or anyone you know have had a similar experience to this case. And I think it'll be helpful for us to understand, what the impact is of the people who are joining us. So, in terms of the approach here, I don't know if there's an echo. Are you guys getting an echo too? Yeah, there's an echo coming through. Okay, let me see if there's something we can do about that. I think that's a little better, whatever that was that did it. So I think that one of the first approaches is just understanding how long have they been trying for, because a lot of couples have difficulty in the beginning. I actually once did a study to look at and see how quickly do people successfully consummate marriages, and I had 100 couples, and we asked the men and the women, and we did a study, and we actually looked at and in halachically observant relationships, and what we found was that only about somewhere around 60% to 70% actually were capable of consummating by the end of the first month, which means that a lot of people don't necessarily, and only 30% were actually consummating within the first night. So I think a large part also is trying to give people that educational level of understanding what is and what isn't normal. But what I think that one of the main issues here is trying to understand why she's having pain and trying to see if we can get to the bottom of what is the source of her pain.
I think it's an important point also that what about this case study is that, which is somewhat atypical sometimes, is that she actually had seen a gynecologist prior to marriage. And I think that particularly in the observant community, I oftentimes see a trend where women are afraid to visit the gynecologist before marriage, whether it's they're afraid of that they're going to have the disruption of the hymen or whatever it is. And I think I can't emphasize enough how important it is that a woman prior to marriage be able to be seen by a gynecologist in order to just make sure that everything is okay. And that doesn't necessarily mean that they're going to have a speculum or a pap smear or something like that prior to the wedding if they're not comfortable with that. But certainly a doctor to be able to take a look, physician to take a look at the anatomy, make sure that everything is within the realm of within normal limits before they even start. Because I've seen women in the past where they've never seen a doctor before they get married and they're having problems. And sometimes it's something that's anatomical that could have been picked up before the wedding. So it's great that this woman did see a doctor before. So we know already that all the anatomical pieces are normal and that whatever's going on, we need to be able to help them. But that's really important to be able to rule out. So I really can't emphasize that enough. That women go to see a gynecologist before the wedding, and also being open and expressing any sensitivities or concerns they have with the doctor if they're not familiar with the Orthodox community. Explaining that if they have not been sexually active before their wedding, letting them know, and so the doctor can conduct their exam appropriately.
It's interesting too. It's funny. We kind of also assume that people understand what it is they're supposed to be doing. She did go and have kala classes, and she did have discussions about intimacy and intercourse. And, I remember the first time I gave a talk on intimacy, and I told a story that Rivki told me not to tell, about a couple that was having intercourse that ended up, it was actually anal intercourse that they were having and did not fully appreciate or realize their own anatomy and what was actually occurring. And the fact of the matter is that a lot of times, even just the mechanics of this can be challenging for many couples in the beginning. We're taking in most halakhically observant couples, we're taking people who have never or maybe have had minimal contact with someone of the opposite sex before they're married. They come into a circumstance where all of a sudden they're going from 0 to 100 in one evening. And so it really is very challenging for a lot of couples. But in terms of other medical issues here, so for me, some of the things that I'm always interested in when these circumstances, is she taking any type of birth control, which could be impacting things relating to discomfort? Usually someone early on like this, it's less of an issue, but it definitely comes into play. Another thing which I think is also very important and gets discounted frequently is history of the person. And whether there's a history for this person. We're in a month right now of recognizing mental health and really the issues of mental health within the community. And the fact of the matter is, there is a large amount of abuse which occurs that can have major impacts, and frequently these things are not dealt with. So when I approach someone like this, I always utilize what I call the biopsychosocial spiritual model, where we look at all the different aspects, and it has to be, all those pieces have to come together. Bracha, what do you usually encounter, like when this woman comes to you? How do they usually come to you? What are the biggest issues that you deal with?
Right. So sometimes that might be a kala that I taught, and they're calling me that night or the next morning to say, sometimes we're not really sure what's happening, or we've tried a couple of times and it's really challenging. Often I tell my kalas, as Scott, as you mentioned, a lot of women do go on birth control prior to their wedding, or some hormonal birth control to manipulate their period so they are able to go to the mikveh before their weddings, and then try to ensure that they're not on chupat nidah, that they're not, they don't have their period at their wedding. And sometimes kala teachers, and hopefully all kala teachers, give them the suggestion and the advice that until they've actually consummated their marriage or actually had sex, that they go ahead and continue on their birth control. Because what can happen is a couple can assume, oh, I'm going to have sex the first night or maybe even the second night, and then they stop their active pills, and then they get their period. And that's another added layer of frustration that can occur, because now they haven't actually had sex. And then we run into some of the issues of yichud, which would be a whole discussion that I would talk about with a woman. So that's something that I very strongly emphasize. A woman needs to keep taking her active pills until she's consummated her marriage, so that she gives herself that time to go ahead and not run into the situation where she gets her period. A lot of the times the couples have gotten to a point where they're just nervous. They're not sure. They really don't know. Sometimes we can try and figure out in discussions that I have with them about what exactly did happen. But they're concerned about a secondary issue, which is also the issue of shechvat zera, the idea that a man is not supposed to, is only supposed to ejaculate within the context of vaginal intercourse. And so there's this concern, and it's an added layer of pressure. So I tell the couples when they call me, we're not really, yes, it is a concern, but right now what we're concerned about is the woman's pain, her discomfort at this point, the frustration that might be building up, and trying to go ahead and get a handle on that situation, so that and try and limit the stress and limit the added layers of concerns and issues that they may have. And as we all know, this is a very uncomfortable conversation for a woman who feels like she should know, right? Scott, as you mentioned, the anatomical issues, that we make a lot of assumptions about couples, and even couples that you may go through with them in kala classes, what the mechanics, unless they're actually experiencing the mechanics, it's a little different than hearing about it. And so they feel like they should know. or certainly there's almost an expectation that he should know what's going on and he should be able to figure it out. And then they can't figure it out together. And are they comfortable talking about it? Have they talked about their expectations for that night even? And then they're uncomfortable talking to each other. And then certainly she has to pick up that phone and make a phone call and say, I'm not sure if we actually had sex, and then share all of these personal information. And even as close as a relationship as she might have with her college teacher, it doesn't mean that she's comfortable sharing this. And then to then send her back to her gynecologist or to a physical therapist, it's another person that's coming into this private area of the couple's life, and it can be really uncomfortable, and that's Rivki. I'm sure you experience that a lot with couples who come to you in these type of situations.
Yeah, it's it's emotionally and physically, a very uncomfortable situation. And one of the things that I would say is really important to emphasize is that if they're having pain with attempts at having intercourse, that the more that they attempt and it's painful, the harder it becomes to kind of untangle that situation. So if she's having a lot of pain one time, twice, like that's enough. Like they already need to be having someone to help them, because a woman should not be enduring pain with attempts at intercourse. And I think women have this idea many times, and many women probably are very, don't think this is true, but many women I've treated do think this is true, that it's supposed to hurt the first time. It's supposed to hurt the first few times, or it's supposed to hurt while you're trying. And the amount of pain that women in my office have reported to me that they've endured, when I ask them on a pain scale, what's it like when on a pain scale of 10 being like the worst pain in the whole world, 0 being no pain at all. And if you've ever, God forbid, been in the hospital and they show you the little smiley face and you like want to punch them. But I always say put number 4 at like, no offense to dentists, but you're at the dentist's office and they've got like both hands in your mouth and it's like super awkward. You're like, Arr! It's like not painful. It's just like really uncomfortable. So that would be like a number 4. I've had women tell me 28. So we don't want that. We really, I always tell people it should hover somewhere in the 4 to 5 range, like uncomfortable, like maybe not, feeling great yet, because it's really just a beginning of, of trying something new and different with your body that you haven't done before. But if they're off the charts with the pain, then there's something wrong. And the woman needs to know, not something wrong like catastrophic. It means they need to reach out for help. They need to reach out to the Yoetzet. They need to reach out to the college teacher or to a medical professional to kind of, talk to them about what's going on so they can get some quick intervention. And really women should not be suffering like that. And certainly that should not go on. Because the longer people, oftentimes when they call my office, one of the first questions they ask me if they're having difficulty having sex or they're having pain with sex is, how long is this going to take to fix? It's kind of like, you bring a car to the mechanic, like, so how long is this going to take to fix? And I don't blame them, because I would ask the same question. But my answer that I've, kind of over the years come to is, the longer this has been going on for is oftentimes how long it's going to take, is the longer it's going to take for this to be able to be resolved. So the longer a couple is going on like this, and I'm not saying that they need to go to physical therapy the first night because they weren't able to have sex. As Scott pointed out in his survey that he had done in his study, that many couples, are not, it takes them a while to be able to have full penetration. And, you often hear people say it's not a goal. It's not a destination. It's a journey. It's a journey that this couple goes on together and building the relationship, both emotionally and physically. And if they're both kind of happy at the pace they're walking at, and they're, learning about each other, learning about themselves in ways that they never really knew about, because they weren't sexually active prior to marriage, then that's great. But if that journey is leading to pain for either partner, then that's really the time for them to step in and try and ask for someone to help them out, because they really, that just causes so much stress and so much strain, both on the side, if it's a woman who's having the pain, on the side of the woman, because she's enduring all this pain and maybe she's just grinning and bearing it, or maybe she's screaming. And for the husband, because he feels awful, because he feels like he needs to get this done. And he sees his wife in horrible distress, and this is just too much. It's too much for the couple to bear, and they shouldn't. They really need to be getting someone to help them, so they're not in that kind of situation. It
there was
oftentimes it can be resolved very quickly. And that was the other thing to say is that, this is resolvable.
there was a question that came through asking about when to refer somebody. And I can tell you that from my own personal experience, I'm a believer that basically by the time they're going to mikvah the second time, assuming that she got her period sometime within a couple of weeks after the wedding, and then they're going to the mikvah the second time. By the time they're going to the mikvah the second time, when she goes to mikvah that time, if they're still having problems, is usually my time frame that I use to say, because if you think about it, you gotta have a little time together. And again, that could be variable based on a variety of things. But as part of that, someone had asked as to whether or not, in terms of psychological and relationship based versus physical, and that is definitely a major piece of it. But I am biased in as much as saying that I always believe that you have to first start with examining the physical aspects of what's going on. There could be hymenal issues. There could be anatomical issues. Many women, even if they went to the gynecologist before they got married, they may not have been examined, and they may not have had an internal examination. And also just to clarify something, I'll just throw this out there, even though it's totally unrelated. It is possible to have a totally normal gynecological examination without it impacting the hymen in any way. So I know a lot of people are hesitant or nervous about getting gynecological examinations before getting married. And I'm not saying you should or shouldn't. I'm just saying that the fact is that if someone does need an internal examination, it does not necessarily impact that. But I always say that I think you do need to start with the biological, because even if there is a psychological or a relationship issue, if there's a physical issue at play, it will not get better unless it's dealt with directly. So just to put that out there.
Yeah, and I also, somebody had said before about psychological, and I just want to speak to that point for a minute. So many women come into my office and they've been told by so many people that their problem is in their head, that there's something wrong with them, that, they don't, for whatever it is, that it's psychological, that, that it's, and I think it's really important for women to know that if they're having pain, that it's real. And not to let anybody tell them that it's in their head. Scott has often said to me, when I talked to him about pain, he said, well, if you chop someone's head off, then they won't have any pain anymore. Of course pain is in your head. Of course, our brain regulates the way that our body interprets pain. But I think so many women bear this embarrassment or feeling of shame that, there must be something wrong with me, that I'm having this problem. And I think it's really important for women to understand that if you are having pain, it is real and it needs to be addressed and it needs to be respected. And if the person who you're seeing is not, treating you in that manner, then you need to find somebody who can, listen to you and listen to your story and believe you, because that's really part of the process for women to be able to feel that they are being listened to and not being brushed off by have a glass of wine, just relax, and everything else that everybody says. So, it's really important for them to know that their pain is real.
Just have a baby and it'll all be better.
Oh yeah, that's another one. That's my favorite. Well,
so what I think emerges from this situation and our discussion here is that this is a real situation, and in order to begin to resolve the situation and find a solution that works for the couple, there's a multi-pronged approach, working with the halachic considerations, the medical considerations, the physical considerations, and ultimately potentially the psychological considerations. And what's most important is that a woman should feel that and a couple should feel that they're not alone, that there are people that they can reach out to, and that there are a lot of resources. The three of us are resources. There are many other resources out there for women and couples to turn to, and for either people on this conversation tonight to go ahead and know that and to share with their friends.
And I'll just add also that there is help. Like, I think sometimes women get these kind of diagnoses, vulvodynia, vestibulitis, vulvar vestibular, all, 100 different names for pain with sex or pain with, attempts at intercourse. And I think that it's important for women to know that that's not a death sentence, that this gets better, that this can get better, and this will get better, God willing. And there's a very effective treatment. And it doesn't mean that they're condemned to a life of either having no sex or having very painful sex, that there's treatment readily available. We know so much more than we did 10 years ago, 20 years ago. And there is so much treatment available, and people do really well with treatment. I think it should be a hopeful feeling that they should be feeling that there's help out there, and there are people who specialize in this and can help them.
The one important thing too, I think, is that it's important that they remember this is a couple issue. A lot of times it's her issue, it's his issue. One of the things that's important for people to recognize is that it's their issue. It's an our issue, because unfortunately that sometimes does create circumstances which really just makes one of the parties feel wrong. And often the fact of the matter is that when you're dealing with these things, you have to remember we're dealing with a couple in these circumstances. We're not dealing with just the individual. And for me, I know, because what happens is usually the only person who I see is the woman who comes into my office. Sometimes the husband is there, and I actually usually encourage her to bring her husband with her, because the fact of the matter is that he has to be clued into what's going on too. If all of the treatment is focused on one person or the other person, then you're only getting to 50% of it, and it doesn't really help. In the long run, you're not going to get the maximal benefit that you can get.
Okay, so now we're going to shift to our next stage of life, which is postpartum. In this situation, a woman has a relatively normal pregnancy. She had some tearing at birth, but she seemed to be feeling okay. She did her bediko during her Shevanikim, and they were extremely painful. In addition, postpartum now, she has urinary incontinence. She was under the impression that it was normal to have a little bit of urine leak when she ran or incorporated jumping into her exercise routine. She also complained that intercourse was not pleasurable and was told that it isn't usually for months after childbirth. And in addition, she was referred when she called her OBGYN, she was referred to a pelvic floor specialist. And also, when I was asked this question, there are also different considerations. As you see, Scott put up a poll again to ask anybody, has anyone experienced this or known anyone who's had a similar type of situation? So we have to break down again here too what the main issues are. Here she's had tearing, she has had painful bediko, she has experiencing incontinence, and she's experiencing a lack of pleasure in intercourse. So again, thinking about some of the things that we discussed, Scott, what would you suggest at this point? This would be a woman who need to be referred. So a woman comes to your office in this type of situation. What are the types of approaches that you take and questions and that you ask her?
I think the first thing to understand also is, did she have any issues before the pregnancy? A lot of times, like I said, people had issues. Many times couples get pregnant right away. They're married for a month or two, and they manage to get pregnant immediately. And what ends up happening is that a lot of times there may have been pre-existing issues. So that's an important component. I think another important component is also, it says that there's tearing at birth, and it's very common for women, especially during their first delivery, to have a certain amount of tearing. It's not uncommon. And there's a bit of a misconception, though, that people think that if you didn't have a lot of tearing, that you can't have particular sensitivities at the site of where the tearing existed. And the fact of the matter is that you can get a lot of sensitivity at the location where the tearing was based on how the repair was done. If there was a repair that needed to be done, the way that the skin and the tissue there heals. You can get scar tissue that forms over there that can cause problems. it's also normal, I mean, the other thing I would want to know for a woman like this is she breastfeeding? Breastfeeding plays a lot into many of the types of issues that someone may be experiencing. And so therefore, when a woman is breastfeeding, the hormones in her body goes into almost like a menopausal type state. And so what happens is that the tissues of the vagina may get very thin and can become much more sensitive because of the fact that the way the hormones that work at that period of time. The urine leakage, this is something which is always fascinating to me because people always, there is an assumption, and it is normal to have a certain amount. It is possible to have a certain amount of urinary leakage after a delivery. There is trauma that happens to the pelvic area, but it should be something that resolves relatively quickly. Usually within 4 weeks, we usually see significant improvement in any of that. And it shouldn't be something that persists for an extended period of time. And then in terms of, the pleasurable thing, again, the pleasurable thing holds a lot of different aspects to it. Is it because she's having pain? And therefore, well, if it's pain, it may not be capable of being pleasurable. Or is it because of other hormonal things? Or is it because of the fact that she hasn't gotten more than 1 or 2 hours of straight sleep for the last 3 months, and she's completely exhausted? Which we can never, I mean, anyone who has had a child or understands what it is in that beginning and the amount of just utter exhaustion that sets in. So there's a lot of factors that come at play here. And this is something also I would want to know about what she's doing for birth control, just like breastfeeding. Things like a lot of times people are using spermicides initially. That can cause a tremendous amount of irritations to the vaginal tissues. But also regular birth control pills can really cause a significant amount of changes in terms of the hormonal milieu inside the body, which can also play into this somewhat as well. Usually if I saw this and it was something that it is normal. Look, if she did have tearing, it's normal that there's going to be a certain amount of discomfort that may exist and persist for 3 months. Past 3 months, if she's still having discomfort, and 3 months is really the upper limit there. But if after 3 months she's still having discomfort, then I would probably refer her to pelvic floor PT in order to be able to get some assessment. And to be honest with you, I think that one of the problems we have is that we don't use pelvic floor PT enough. Not that I'm biased here. The fact that my wife is one, she's not paying me to say this. But
I'd see her earlier than 3 months, Scott. I would see her. Soon at 6-week visit. Give the okay.
That's what I was just about to say. Is that I actually think that one of the problems we have in this country is that we don't fully appreciate the value of what pelvic floor PT does in terms of rehabilitation. This is a major muscular traumatic event that happens giving birth. In other countries, and Rivki could speak to this better than I can, pelvic floor PT is initiated immediately after delivery, if you really think about how much trauma occurs. So it's something which I think is underutilized and underappreciated for the value of what it has to offer.
Yeah, what I was saying is I would see her, as soon as the gynecologist gives the okay for physical therapy, I see women 6 weeks, after delivery for this kind of thing, 6 weeks, 7 weeks, as soon as, they're stable enough, healed enough for that. Absolutely. The other question I would ask also is, she complained that intercourse was not pleasurable. I would just point out, and I think Scott, I don't remember the statistics of, for many women, was she having pleasure with actual penetration before she had a baby? Because there are many women who, never achieve orgasm just with penetration alone. It has, that they're actually having most of their arousal occurs with other things other than penetration. So the question is, was that pleasure for her beforehand? Was that where she was, deriving her stimulation from? And also could she also be having a lack of, have some sensory problems where there's some disruption of nerves that are no longer transmitting the right signals anymore because of the disruption of the tissue that went on with a delivery like that. And I would say that also that urinary incontinence, like Scott said, is, normal, perhaps for a small window after delivery, but it's maybe very common in women. I think a lot of women think that, having urinary leakage is kind of what happens when you get older. It happens when you have a baby. And I think that the aisles of incontinence products in Walmart, will suggest that that's just, something that just happens and that's normal. And I would say it's extremely common, but it's not normal that a woman continues to have leakage. And it's really, it's telling her that something is going on with her body, that her muscles are not working that they're supposed to be. And that they certainly, just like any other muscles in the body, they can be retrained to do the function of holding back urine and not having that kind of leakage. When we have a woman who's having leakage with jumping or sneezing or coughing, I think this one she was leaking when she was doing her exercise or something like that. Was that what the case was? We call that stress incontinence. And, and that's particularly difficult for women who, after they have a baby, they want to get active again. It almost like interferes, forget about their, dignity and feeling like they're in diapers and their baby's in diapers, which is just awfulness, but also that, they want to start moving again. They want to get their life back. They want to get their body back. They want to be able to move and go out and do stuff. And they're not able to exercise because they're afraid that they're going to leak. So it inhibits their ability, it interferes with their ability to get, to be able to rehabilitate and get stronger, get their body stronger again after having a baby.
I'll tell you that when I see someone like this too, I usually will tell them they need to speak to their Yoetzet or their rabbi to talk about the bedikos as well, and to see if there's something which could be done with the bedikos, because sometimes, again, there is that extra sensitivity. And so, I don't know. Do you see a lot of that, Bracha?
Yeah, I do. Postpartum in particular, bedikot being painful, being difficult, and some of it is physical and some of it is nervousness, and all of it can make the bedikot more uncomfortable. I often tell women when they have a baby, they should call me. I walk them through what to expect during labor and a little bit post-labor. And I tell them, call me 3 weeks postpartum, 3 or 4 weeks postpartum, so we can begin to have that discussion proactively, aside from discussing birth control, but also proactively about what could happen during the Shevanekiyam, what could happen post-mikvah, also thinking about their own personal expectations of sex postpartum when they come back from the mikvah, and what their communication is like with their husbands. But in addition, just talking about the certain leniencies that might exist for bedikot. There are some women who breeze through the Shevanekiyam postpartum. It's not so challenging for them. They're able to do it, and it's fine. But for other women, it can be, as for this woman, it can be very difficult. So there are some leniencies in terms of either putting something on water on the bedika cloth or putting some kind of lubricant internally. Those are two things that can make it easier to go ahead and do the bedikot. Not necessarily going in as far. That can also be a leniency. And then potentially also not doing the moch, and then also reducing potentially the number of bedikot. And I tell women, go ahead, you're going to try the hefsek tara, and then you're going to be in touch with me. And then we're going to try and see, okay, how do we need to go forward in terms of giving that advice for women, and hopefully that helps a woman. But if it doesn't, if that is too much for her and it's too painful, then we have to discuss even more what other types of leniencies are. But I do like to think proactively, so I don't get a woman who's calling me on day 3 of her Shevanekiyam in tears because she's trying everything the way that she did before she had a baby, and it's not working exactly the same way. And then suddenly in her mind, as I'm sure Rivki and Scott, you've seen, in her mind now, these bedikot are painful. So as painful as they were, they're now so much more painful because she has that added psychological stress now of they're painful, and then she clenches her muscles, and then any lubricant that she might have personal lubricant that she might have had dries up, and then makes the petticoat even more painful. And here she is also hormonal, and things are challenging. As Scott said, she might be sleeping for an hour or two a night, and all of that can end up expressing itself in the challenges that she has postpartum. So we want to be, obviously, within the realm of halacha, we want to be as sensitive as we can to a woman and her individual situation. So yes, I do get lots of questions like that, lots of calls like that, postpartum, about women who are trying to navigate the Sheva Nakia under different types of circumstances in terms of her own personal circumstance. And Rivki, go ahead.
I was just going to say, one of the things that I find helpful when I'm seeing patients like this is to actually get on the phone with the Yoetzet or the Rav or whoever they're seeing, so that we can have a discussion together if the patient feels comfortable with it. Because I have to tell you, a lot of times when I'm dealing with these circumstances, there's a little bit of a telephone that takes place sometimes. When I talk to the patient goes and talks to the Yoetzet, then they come back and they talk to me, and things get lost in translation. And a lot of times, many of these issues can be resolved very quickly and very easily when that communication is open. And it's something which I think, is something which I hope people are getting a little bit from our discussion here, is the idea that for, this is a multidisciplinary approach, if you will, where a lot of people being involved is critical, but just as critical is encouraging the communication to take place. And so if you're seeing your doctor, I mean, this is something I advise patients all. If you're seeing your doctor, let them know that, your rabbi needs to be part of this. Your Yoetzet needs to be part of the discussion in some fashion. And most physicians will be more than willing if you give them that notice in advance, if they're not necessarily sensitive to religious issues. But I do think that is very important. I'm sorry, I interrupted you before.
I thought you were going to say. I'm sorry. I thought you were going to say that that you need to let your doctor know. I think that that women need to let their doctor know if they're having any of those symptoms. I think a lot of times women go to their checkups and they do the breast exam, they do the pap smear, they do everything else, and they neglect to mention that, oh, and by the way, sex is unbearably painful, and oh, by the way, I also leak urine every time I jump and I make a puddle on the floor. I can't move without leaking. And I think that women understanding that those situations they need to speak up for themselves, and they may not be asked those questions by their doctor, depending on how much time the doctor has to spend with them, and a myriad of other things that relate to the doctor's experience in working with these kinds of patients. But knowing, obviously not you, Scott, because people who are experienced, who deal with pelvic pain all the time, but to say, just because they didn't ask about it, it's really important that you let your doctor know, hey, sex is really painful, or I'm leaking urine and that's really difficult, obviously. But I think that's really important that they speak up for themselves. And just a word about the bedika, and I think both in this case and the previous case, which was important, is that if a woman is having pain and so much difficulty with the bedika, whether it's, before their wedding, and hopefully they would find out, by, as I've spoken many times before, about using tampons during teenage years to find out if they're having any sensitivity in that area before the night of the wedding is always really useful to know. Or if they've never had any problems before and then they've had a baby and they're trying to do this bedika and it's excruciatingly painful, that likely that sexual intercourse is not going to be easier. Is not going to be easier if the bedika cloth and the bedika is so painful. That's a really good sign for them that they really, both that it will help them from intervention perspective, having some physical therapy ahead of time to kind of help them have their body, be able to recuperate or be able to have less pain with something touching the vaginal or the vulva area, but also it also gives them confidence in that whether it's a new bride who is so worried that the B'dik cloth was so painful and they're worried about intercourse, or whether it's a woman who's just had a baby who's having so much pain in the area with attempting a B'dika, coming for physical therapy or for pelvic floor therapy is extremely helpful in that way, that it gives them confidence in that they feel like, oh, okay, I can resume or I can start a sexual relationship without this fear in my head that this is going to be painful, because I know it's not going to be, because I've had this treatment and we've worked together, and it gives them the confidence to feel like they can really inhabit their own body with confidence as they re-enter or enter for the first time a sexual relationship.
There's one thing I realized that I'd be remiss also if I didn't mention on this case, which is, there were some questions about libido and how long it's normal postpartum to return. And I think one thing that I forgot to mention here, which I think is critical, is and I don't want to get into detail about it, but about postpartum depression and postpartum anxiety. And these are very, very common conditions. Let me not true. These are common enough conditions that impact a large number of women and are things that really do not get enough attention. And many of these other symptoms could be manifest in women who are experiencing postpartum depression. So it is real important for people to understand that, and for people for that conversation to start becoming more prominent and accepted, because I think, unfortunately, we see a lot of it. We know that during COVID, there's been a spike in the amount of mental health disorders, and in particular, postpartum depression. We're seeing some of the highest rates of postpartum depression that we've ever seen during COVID. And someone mentioned here also about how long does it take in order to get to normal libido postpartum, and the answer is there is no answer. Everybody is a little bit different, and it depends on so many factors. But what I will tell you is that once you're starting to hit about 6 months, if things are still really an issue, especially if you're not under a particularly undue amount of stress in other areas, that's probably time for you to start to seek out some help. And you could go a little bit earlier than that if it's really bothering you. And really, if it distresses you, you should be seeking help for it.
Okay, understanding and thinking about, while some of the issues that we've addressed are particularly related perhaps to someone who is newly married, someone who is postpartum, some of these considerations of pain, play themselves out in different stages of life. So the next case we wanted to look at is a woman who is a 49-year-old mother of 4. She's got lots of responsibilities, a full-time job, a family to take care of. Perhaps she has parents that she's also taking care of that while she's taking care of her own children, and she's really trying to juggle it all. Since her last childbirth, she has experienced urinary and fecal incontinence and has very little desire for sex. Every night, she simply wants to go ahead and just fall into bed. She does want to be more focused on her intimate relationship with her husband, but life stresses, exhaustion, her lack of libido, and her incontinence are really impacting the desire for sex that really just isn't there. And in addition to working with a psychotherapist, she was suggested to work with a pelvic floor specialist. So here in this situation, this woman is experiencing a lack of desire, low libido. She's got urinary and fecal incontinence, and she's got a tremendous amount of stress in her life. So in this kind of situation, often a woman really needs to be referred to a pelvic floor specialist. And Rivki, I would ask you here, a woman like this who is referred to you, how would you go ahead and help her? What would you advise this woman, or how would you treat her?
Right. So I think that, one of the first things is you want to make sure that everything is medically stable. Physical therapists are fantastic, but you want to make sure that there's no underlying physiological issue going on, whether it's hormonal or otherwise. I think, Scott had mentioned like thyroid at some point. You want to make sure that there's nothing else, perhaps Scott could also speak to that at the end about, what other things might be contributing. You really want to rule out all those other things so that you want to make sure that you're not missing something. Myself as a physical therapist, I want to make sure that I'm not missing something that's really outside the scope of what a physical therapist or any pelvic health therapist can be could be trained to treat. Okay, so that would be the first thing. You want to make sure there's nothing else going on. And in terms of the urinary incontinence and the fecal incontinence, what we would do is really take a look at what's going on with her muscles first. First, we would take a history, find out, her childbirth, does she have, she has children, what were her deliveries like? And what we oftentimes see is sometimes women, our bodies are amazing at compensating. And oftentimes, maybe there was something that went on in a delivery or a pregnancy when they were, 25 or 35. And now that there are hormonal shifts and changes in their physiology as they age and hit perimenopausal ages, that the body's ability to compensate for some of those deficits and some of those weaknesses diminishes. As our body ages, it's not as resilient as it was. And so some of these issues that maybe the body started with childbirth, let's just blame everything on childbirth, why not? But, now their body was younger, and perhaps they had, more their resilience in terms of being stores to be able to not have these kinds of problems. Or perhaps they were so busy with little babies that they were never really paying attention to the fact that they were having all these problems, or these problems were emerging. And now that they're, reaching in their 40s or 50s, and they're like, hey, wait a minute, hold on, this is all going wacky and I don't know what's going on in my body anymore. And I see this a lot. And, I really enjoy telling 60-year-old women that their problems are really because they're postpartum, and they usually enjoy that. We have an adage that once postpartum, always postpartum. And I think, taking a look at, birth history, also illnesses or medications or surgeries, or if they've had any, any kind of cancer treatments, certainly can contribute to changes in the tissue that can contribute to some of these kinds of changes that occur. And in terms of treatment, so first we want to take a look at those muscles, see what's happening with their muscles. And just like we would rehabilitate, I know we're running out of time, and I could give an hour lecture about how I'd rehabilitate. But basically, just as much as that, if you had a problem with your shoulder or your elbow, and your physical therapist would say, if anyone's ever had that, flex, extend, it's kind of similar, but we're just translating all that to all the muscles that you sit on. How's that for on one foot? So, that's absolutely, we absolutely can rehabilitate the muscles of the pelvic floor, those muscles you're sitting on, if you know what they are, that run between the vagina and the anus. They certainly can be strengthened. They certainly can be taught to work better together than they had been. And these issues can definitely be resolved with physical therapy, just as much as any other part of the body that's having weakness or dysfunction. And fecal incontinence and urinary incontinence oftentimes are a result of, problems with the pressure system in the body and the muscle system, and many systems working together or not working together the way they should. And a good physical therapist can help, who's trained in this area, to kind of bring all those systems back to working in symphony together.
Now, when you go, I'll just say this quickly because we want to provide an opportunity for questions. When one goes to a physical therapist, they would go to Rivki. They may use certain instruments internally, and there are some halachic dilators and other instruments. And what's important to know here is sometimes a woman is specifically going during the Sheva Nikiyim, because that can sometimes be, as Rivki has mentioned, the ideal time for different reasons. And then there's the question of, does a woman need to ask her physical therapist if she sees anything? So there are definitely different schools of thought. One school of thought is that a woman is not under any obligation to go ahead and look and to go ahead and ask, but she's already doing her badikot. And what she could say to the therapist more generally when she starts treatment is, don't tell me what you see. You don't have to tell me. That's whether you're seeing from physical therapist or somebody who's not Jewish at all. And the truth is that even if the therapist does say something, yes, we have to kind of figure out and investigate. but sometimes we can also say that this is a shad hatzchak. This is an extreme, exceptional type of situation, and therefore we might be able to be lenient. Can we attribute anything that a woman is seeing to perhaps some kind of irritation in the area because of the pelvic floor therapy? And that's something just to take into consideration when going to a pelvic floor specialist that has come up in questions that has arisen in the past. I know that we're running out of time. We wanted to look at this last case, which is a perimenopausal woman who's 53 and she still gets her period. It's not necessarily regular, but she is finding it very frustrating because it is irregular. And she's also at the beginning of uterine prolapse. And she's also perimenopausal. This woman who came to me said that the last time she went to her gynecologist, this is what her gynecologist told her. So there are lots of different considerations that we need to think about from a halachic perspective, how we're dealing with the shevanikim and the irregular staining. It's important here to remember the laws of staining and to know that what colors are a problem and what leniencies we might have in terms of that staining, and then also thinking about when a woman is anticipating her period, her vestote. There may also be certain leniencies in this type of situation, and it's important to go ahead and ask that question. Also, around the age of 53 is halachically when a woman is entering into the stages of being a menopausal woman, and therefore, again, might also be certain leniencies in terms of calculating vestote. I know that we're kind of running through this so that we can give you a little bit of an overview, but just turning to Scott and Rivki, what would you suggest about this woman and in terms of going ahead and helping her in some of the issues that she might face?
I think that, I'm just going to make a comment about irregular bleeding in general. It is normal for women as they get closer to menopause for their menstrual cycles to become more irregular and a little bit more sporadic. Typically, it's that they get more spaced out. However, if people are experiencing heavy bleeding, if people are experiencing prolonged bleeding, if people are experiencing too frequent bleeding, or if somebody hadn't bled for like a year and then suddenly starts to bleed again, these are all causes that you do need to go to your doctor to get checked out. I've seen already several cases of people who unfortunately have had bad diagnoses because they allowed some of these types of things to go unchecked. Like I said, most of the time, people who are in the perimenopause, it's normal for transitions to take place, but it really is so critical that you don't just ignore it, especially if it's persisting, because it could be indicative of a bigger problem. I mean, Rivki, if you want to talk about the prolapse. I think you're muted, Rivki. I think.
There we go. I was having a problem with the mute button. So prolapse, for people who don't know what that is, basically what happens is there's a lot of muscles and soft tissue that kind of holds up all the organs that are in the pelvis. And sometimes, and the way that someone explained this to my patients is, if you imagine that the room that you're in is the vaginal vault. And above you, and then there's a room above you. The room above you is the uterus, and the room below you is the rectum. So it's not an exact analogy, but imagine that your neighbors upstairs are stomping hard, and your ceiling starts to kind of cave in. So you see your ceiling kind of sloping a little bit, and it's due to something that's going, the people upstairs, the floor upstairs. It's not that your actual neighbors are coming through your floor, but you start to see like a sagging into your vagina, into your house. And then, or let's say that the people who live below you, I don't have water damage or something in their ceiling. And now you have a bump in the floor below you. And so in terms of how that translates is sometimes because of the alignment of the way that the vagina and the rectum and the uterus are all positioned within the pelvis, you sometimes can, over time, when there's vaginal delivery, can contribute to this, what we call prolapse, where organs start to sag into the vaginal vault, whether it's the uterus or whether it's the bladder or whether it's the rectum, causing kind of, you can kind of, sometimes women can feel the something bulging into the vagina. And the complaint that I'll hear often in my office is, I feel like heaviness in my pelvis. I feel like something is down there. I feel like something, a bump. I feel a push. And sometimes women will find it when they're having a badika, they'll feel something bulging down. Sometimes when they're having a bowel movement, they'll feel it. So within the first couple of stages, physical therapy could be extremely helpful in helping to strengthen the muscles around the area to kind of help hold all that up, help everything kind of be pulled back into place. Well, you can't really change the structural without, with physical therapy anyway, the structural changes that are happening by good strengthening, by posture work, lots of things that we work on in physical therapy. Women can get some relief of some of these symptoms that they get, of the heaviness in the pelvis after standing for long periods of time, starting to feel a bulge in the vagina, may interfere with intercourse. They feel a bulge, might interfere with bowel movements or in functioning. And physical therapy can be very effective in that area as well, in terms of strengthening the area and helping to reduce the symptoms of what they're feeling.
Okay, are there any additional questions that people would like to share with us? I know that we have run over time, but I think, okay.
We could talk for hours.
Right. There's so much more to talk about and so much more to share. And part of our goal here also, in addition to seeing the interplay between medicine and halacha, was that we wanted to show you that this is something that really happens to people. It's not something that you just read about or you hear about. As we saw, Scott was putting up the polls, that people know people who this has happened to and have had these experiences. And we want to, on some level, we want to normalize this for you. And we want to show you that there are resources that are available for you, and that as uncomfortable as it can be to pick up that phone, as uncomfortable as it can be to share this information, because am I the only one who's experiencing this? I can't tell you, and Scott and Rivki can say the same thing, how many times women have called me and I said, oh, I just got a phone call like that. Or, oh yeah, I had a situation like this last week. And I can feel through the phone, or even I can feel that sigh of relief of, I'm not the only one. This happens to other people. It's normal and it's okay. And I can share this information, and there are resources that can go ahead and help me. And that's something that's so important, whether it's for your own experience, for those who are on here, or to go ahead and share with others and to know, pick up the phone, make the phone call. We want to help you. There are ways to go ahead and help the solution. And as Scott said, and he emphasized, it's not a woman's problem, it's a couple's issue. And when we get the couples involved and when we have that communication between all of the parties, it makes it so much better, and we can go ahead and try and work towards a solution. And it's not a one-size-fits-all solution. It's a solution that works for this couple, that will go ahead and ultimately, hopefully, enhance their marriage and enhance their relationship. So with that, Rivki and Scott, if you want to add anything to go ahead and conclude.
Thank you, Bracha. I wanted to thank Nishmat and all the Yoetzet and Atar Ice and everybody, and you, Bracha, for really providing this wonderful resource to women, to everybody, to the whole community, making such a difference in the lives of women over the last 20 years. I can't believe it. Is it over 20 years? Really changing the landscape. So thank you. Thank you for having us.
And I'll just say that we really could talk about this for hours and hours, and I really have. Exactly, and I feel bad that we didn't get to everybody's questions, and I know that a lot of people have a lot of questions, but I think that it's important for you to realize that if you have these questions, go get the answers for it. Listen, this session is not something that's going to be able to guide you to get your treatment specifically. We're not solving anyone's problems in the hour that we had together, or now I think an hour and 10 minutes that we've had together. But it is important. I really want to stress that people go and get help. There's tons of resources. I think it's remarkable what the organization has done in terms of of putting together a conference like this. I think it's impressive, and even more impressive that everybody who logged on, because I'm sure everybody has a lot going on. And I know we're on the East Coast. It's 10 o'clock at night here. I'm sure people have many other responsibilities. But I think it's a testament to our community that people are taking these issues, we're bringing them to the forefront, we're opening the discussion. And I really just want to encourage people to keep the discussion going. It's so important that we normalize, like Bracha said, these things happen. They happen to lots of people. We have to remove the stigma. And the best way to remove the stigma about it is for people to start talking about it. And I think that what this is truly a testament, and I can't give enough thanks to all of the Yoetzet and to what Nishmat and the organization of putting this together. It really is a phenomenal activity.
And thank you, Rivki and Scott, for being a resource for me and for all of the other Yoetzot and for all of the women and the couples that you help. So thank you, everybody, and we wish you a wonderful night. Take care.
Take care. Bye.